Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, it's going to be a short video. We're doing a Kahoot, and it's going to be a little bit different. On this Kahoot, we're going to be going over GIGU. However, this Kahoot is specifically for NP students. Whether you're studying for ANCC or AANP, this video will be helpful for you because I don't go over the questions, guys, but I go over topics that you need to know in order to answer those questions appropriately. So if you know anybody that is studying for their boards, they want to be a nurse practitioner, please send this video to them or go ahead and tag them. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it, so go ahead and give it a thumbs up now. Subscribe to my channel if you haven't done so already. And don't forget, I'm now offering next generation NCLEX review sessions. I'm offering that. I'm offering one-on-one tutoring sessions or consultation sessions. And I also have audio lessons for the students who are current students. You're in the program, you're not even studying for boards, you're just trying to survive the actual program, you're trying to get a higher grade. Check out the audio lessons that I have available. All of that can be checked out on my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms such as TikTok, Instagram, and Facebook. Without any further ado, guys, let's get started. GIGU for the NP student. Okay, so you have a patient that comes in, they're showing positive Cullen's, gray Turner sign, they're presenting with fever, nausea, vomiting, tenderness over the epigastric area, abdominal pain that's radiating to the back. What are you going to initially suspect that this patient has? Is it going to be acute pancreatitis, acute diverticulitis, acute appendicitis, or acute cholecystitis? Again, you have an adult patient that presents with a positive Cullen's and gray Turner sign. They're having nausea, vomiting, tenderness over the epigastric area. They're having abdominal pain that radiates to the back. Acute pancreatitis, diverticulitis, appendicitis, or cholecystitis. What do you suspect the patient has? Very good, acute pancreatitis. So let's talk about this. We know the pancreas is important for so many things. It's an important organ. You know, the beta cells in the islets of Langerhans and pancreas, that's what produces the insulin. The pancreas is responsible for releasing those enzymes to break down food. So the pancreas is very important. Now, those signs and symptoms, positive Cullen sign, that's where that patient has that bluish color around the umbilicus. Positive gray Turner sign. Oh, I spelled Turner's wrong. Sorry, guys, but you know what I meant. Anyway, positive gray Turner sign, that's where the patient has that bluish color on the flank areas, right? You take your two hands, put it behind your back and right where your palm's sitting. Those are kind of, that's around where your flank area is. Patient has a fever, tenderness over the epigastric area, abdominal pain radiating to the back. Now, let me tell you what the keys are. If you are studying for your boards, when you see positive Cullen's, you see positive gray Turner sign, I want you to immediately think of pancreatitis, okay? Because when we're looking at the other symptoms, we're looking at fever, nausea, vomiting. It could be diverticulitis, but we're not going to see that over the epigastric area, right? Appendicitis, we would see right lower quadrant pain. Cholecystitis, well, I'm not going to tell you cholecystitis because I think I made a question out of that. But the key to this question is that positive Cullen's and gray Turners. When you see that, I want your mind to immediately go to pancreatitis when you're thinking of your differential diagnoses. How are you guys doing on the live? Okay. All right. You have another patient that presents with a high fever, anorexia, nausea and vomiting, left lower quadrant abdominal pain, rebound tenderness, board-like abdomen, and band forms. What would you suspect the diagnosis to be? Would it be acute diverticulitis, acute appendicitis, acute cholecystitis, or colon cancer? fever, anorexia, nausea, vomiting, left lower quadrant pain, rebound tenderness, board-like abdomen, band forms. While you guys are choosing your answer, something else I wanted to tell you about acute pancreatitis. Also, the patient may present with signs and symptoms of impending shock. You're going to see the blood pressure go down, urine output go down, heart rate go up, respirations go up. Okay. Okay. Acute diverticulitis. That's the correct answer. I saw a lot of you guys chose appendicitis. And let me tell you something. This is how they try to trick you. Let's go back to these symptoms. High fever. Yeah, that could be appendicitis. Anorexia. Yep, that could be appendicitis, nausea, vomiting, left lower quadrant abdominal pain. Appendicitis, where do we see that? Right lower quadrant abdominal pain. I'm not saying that the patient wouldn't have left lower quadrant pain, but if you're choosing between appendicitis and your diverticulitis with these symptoms, you're going to go with diverticulitis, a left lower quadrant pain. Rebound tenderness, yes, we could see that in appendicitis, same with the board-like abdomen, but the two clues in this question that should have made you pick acute diverticulitis over acute appendicitis, I'm going to tell you what those two things are. Number one, the left lower quadrant pain, because an appendicitis is going to be what? Right lower quadrant pain, and two band forms. Let me tell you something. You see band forms? Patient got to go. That patient's in your office, just like in football. You know how they punt the ball. You won't put that patient right out of your office. They need to go to the ER. Matter of fact, I'm saying this about acute diverticulitis, but the same thing for the first slide when we're talking about acute pancreatitis. Okay. Once you suspect that, patient has to go to the ER. So let's talk about this patient with acute diverticulitis, where all of the other symptoms could have possibly been appendicitis, but that left lower quadrant pain and the band forms. When you see band forms, that lets you know most likely this patient is suffering from a severe bacterial infection. They need to be hospitalized. So with this type of patient, they may also have a positive Rosving sign. And that Rosving sign, that's when you palpate the left lower quadrant, and they may have pain in the right lower quadrant. Even though right lower quadrant pain is usually appendicitis, right? We can also see that in acute diverticulitis, that's the positive Rosving sign. So the thing is, guys, you have to use your critical thinking. You can't just see one symptom and say, oh, well, this goes with this. You have to look at the entire clinical picture. I talked to you guys appendicitis, cholecystitis. I know I did a question on that, so we'll get to that. And colon cancer, I did a question on that, so we'll get to those two. So the important thing you guys need to know about this slide when it comes to diverticulitis, again, is left lower quadrant pain, band forms, and there's something else I want to tell you about acute diverticulitis. It's going to bother me. I'll get back to it. It'll come to me. Okay, I remember. The symptoms of colon cancer are acute and specific. Is this true or false? The symptoms of colon cancer are acute and specific. Is it true or false? Very good. False. The signs of colon cancer are not acute. It's not something that comes on suddenly. It's very sneaky. It's insidious. And not only is it insidious, it's very often non-specific. And the reason why it's so deadly is because it's insidious and non-specific. So by the time we figure out what's wrong with the patient, that patient's been diagnosed, it's already metastasized. That's why it's so deadly, right? All of these other diseases and disorders, patient gets sick immediately, There's specific symptoms. We know exactly what to test for. We catch it in time. Boom, we get rid of it, right? But when it comes to cancer, this is cancer across the board, not only colon cancer. When it comes to cancer, it is sneaky, it's insidious. The symptoms are very non-specific. So by the time we usually catch it, it's already metastasized. So that is absolutely false. I remember what I wanted to say to you guys about acute diverticulitis. Something else about diverticulitis that you can tell the difference between diverticulitis and appendicitis. Another thing, appendicitis, those symptoms are abrupt. You hear me? Boom, abrupt. Patients in pain, they're guarding, they're not letting you near them. But when it comes to acute diverticulitis, that pain comes in waves. So they'll have that pain and then it kind of goes away. Then they have it again, then it goes away and it increases in intensity over days. Where acute appendicitis, that pain increases over a matter of minutes or hours. Okay. So that's a big difference also between appendicitis and diverticulitis. Your boards absolutely expect you to know the difference and to be able to differentiate the two. Okay, you have an overweight female that presents with severe epigastric pain within an hour of eating a fatty meal. They're experiencing nausea, vomiting, and anorexia. What would you suspect the patient to be diagnosed with? Or what would you diagnose that patient with? What would be your differential diagnosis? Would it be colon cancer, stomach cancer, acute cholecystitis, or Crohn's disease? Very good. Acute cholecystitis. What was the key um to knowing that we're dealing with cholecystitis, the fatty meal? And listen, guys, I want to make this clear. Your boards for NP, the questions are not going to be this easy. I'm making these questions just to give you a foundation of what you need to know. Okay. The question you're going to get is going to be much more in depth, but these are the key things that are going to be part of the question that are going to be clues for you to figure out what's wrong with your patient. So, anyway, what we're going to suspect is acute cholecystitis. Chole, gallbladder itis, inflammation of the gallbladder. And that makes sense because if you think about it, what does the gallbladder hold? Bile. What does bile break down? Fat, right? So the more fatty meals the person eats, the more they're making their gallbladder work. So it makes sense that the patient's going to have severe pain in that epigastric area within an hour after eating a fatty meal because they're making that gallbladder work, right? So that's why that patient with acute cholecystitis, you suspect that immediately that patient's going to be NPO. Immediately, you're going to have an NG tube inserted, right? Immediately, that patient's going to be on IV fluids. And the reason I gave this type of clinical manifestations because this is your classic manifestation. Who's at highest risk for acute cholecystitis? It's going to be a female. She's going to be overweight. Okay, and those are going to be your classic symptoms. Now, I saw 18 of you guys chose Crohn's disease. So let me talk about Crohn's very quickly. Yes, in Crohn's, the patient will have abdominal pain after a meal, but guess what? It doesn't have to be a fatty meal, any meal. Any meal, that patient's going to have abdominal pain within the hour of eating. But there are also certain phrases that you'll see in that type of question to let you know they're talking about Crohn's. So, some symptoms you may see is that the patient is having diarrhea, but there's mucus in that stool. Something else that you need to know about Crohn's that boards absolutely expects you to know. Any patient with a history of like Crohn's or polyps, they're at risk. They're at increased risk for colon cancer. You absolutely need to know that for testing purposes. Don't say I didn't warn you. Okay, what is the first line treatment plan for the patient with GERD? So your patient's been diagnosed with GERD. What is the first line treatment plan for this patient? Is it going to be lifestyle changes, over the counter acids, a green tea, or proton pump inhibitors? You guys are so funny on the live. Very good. Lifestyle changes. In medicine and nursing, we always go from least invasive to most invasive unless there's something acutely happening, that patient's life at risk, and we have to um, go to invasive. But otherwise, we always want to go from least invasive to more invasive. So the first line treatment for that patient that has GERD, which is gastroesophageal reflux disease, we're going to teach them lifestyle changes. Stop smoking. Lose weight if they're overweight or obese. Stop wearing tight clothing. Stop wearing clothes that decrease the pressure on the, what's that sphincter called? Uh, the cardiac sphincter. Okay. Stop consuming foods or drinks that have caffeine in it. Stay away from chocolate. Stay away from peppermint. Stay away from tea. All that good stuff, right? So lifestyle changes, that's the first thing that we're going to teach the patient. Now, after lifestyle changes, if that doesn't work, then we'll have to place the patient on medications, and usually the first choice is going to be, which I saw 22 of you guys chose, it's going to be a PPI. It's either going to be a PPI or an H2 blocker, depending on the patient's condition. Again, you're going to have to read the question very closely, see what's going on with the patient to see what you're going to prescribe for that particular patient. But it's going to be lifestyle changes first, and then PPIs or H2 blockers. Okay, so you have an adult patient that presents with acute high fever, chills, nausea, vomiting, one side flank pain, dysuria, frequency, urgency, costovertebral tenderness. What's going to be on your differential diagnosis, or what are you going to diagnose this patient with? Is it going to be an acute UTI, acute pyelonephritis, pregnancy, or hepatic failure? Acute high fever, chills. So we're talking about generalized symptoms, nausea, vomiting. I shouldn't have given you that clue, but anyway, one-sided flank pain, dysuria, frequency, urgency, costovertebral tenderness. There's over 100 people on this live. How come only 58 are answering? Come on, guys. Chicken. Okay, guys. Correct. Acute pyelonephritis. Now, please, on the live, tell me what is the one word you saw, or I'll say two words that you saw in this question that made you know that we were talking about pyelonephritis and not UTI or anything else. Very good. Costovertebral tenderness or flank pain. Patients got high fever, chills, again, generalized symptom, nausea, vomiting, one-sided flank pain, dysuria, that frequency, that urgency, we see that in UTI, right? But the reason we know not to choose UTI is because we see that flank pain. We see that costovertebral tenderness, and we're seeing that generalized symptom, the chills, okay? We're going to think acute pyelonephritis. By the way, acute pyelonephritis, this is considered a complicated infection. So the antibiotics that you would give for this type of patient, it's not going to be a simple 3-day antibiotic. No. If that patient's in your office and you're giving them something in the office, you'd probably give them something like Rocephin, you'd give it IM right there in the office, but you're sending them home. They're going to be on antibiotics for 14 days. You're going to give them something like Levaquin or something like Cipro. Some other things you may see in the question to make you know that this is what we're talking about. If when you look at the urine, you'll see that the patient will have proteinuria. Proteinuria, we may also see that in other kidney disorders, but remember, acute pyelonephritis, that is an upper urinary tract infection. So you'll see proteinuria and WBC CAS. You see those two along with these signs and symptoms with the costovertebral tenderness, with the flank pain and chills, you should be thinking pyelonephritis. Again, pyelonephritis, this is a complicated urinary tract infection. So the patient, remember, if they don't get that one time, Rocephin, IM in the office, you're writing them a script for antibiotics. They're going to take it for 14 days. Remember, if it's complicated, they're going to get the antibiotics for 14 days. If it's uncomplicated, something like, just a regular UTI, it's a healthy, regular adult, they'll get antibiotics for 3 days. If we're talking about a pediatric patient, they're going to get antibiotics for 10 days. It's very important. Boards expects you to know the difference, so make sure you guys study those subjects, okay? All right. BUN is more sensitive to diagnose pyelonephritis than creatinine or GFR. Is this true or is this false? BUN is a more sensitive test to the diagnosis of pyelonephritis than creatinine or GFR is. Is this true or is this false? Very good. That is absolutely false. Guys, so many things can cause the BUN to be high. So if we see the BUN high, we're going to check the creatinine. We're going to check the GFR just to rule out kidney association, just to rule out that the kidney's involved, right? But so many things can cause the BUN to go up. A high protein diet, CHF. What else can make the BUN go up? Medications, certain drugs can make the BUN go up. So the BUN is not specific to the kidneys like creatinine and definitely GFR is. So this is false. Okay, for uncomplicated UTIs, what should be the duration of treatment? Oh, I forgot I made this a question. All right. So for uncomplicated UTIs, what should be the duration of treatment? Is it 3 days, 5 days, 7 days, or 14 days? And I just told you the answer, so everyone should get this correct. How did only 22 of you guys get this right? I just told you if it's uncomplicated, you expect that patient to be on antibiotics for 3 days. When I say uncomplicated, it healthy female, female, healthy female adult 18 or older. Because let me tell you something. If this is a male with a UTI, just him being a male has made it a complicated UTI, and he's going to be on antibiotics for 14 days. Unless you give him that one shot of Rocephin right there in the office, I am, right? So, female, adult that is healthy, 3 days. All right, select all that applies. All right, which patient would be considered complicated UTI and must be treated for 7 days or longer? And when I say 7 days or longer, I meant 14 days, but technically speaking, at least 7 days, but 14 days. We're talking about complicated UTIs. Who falls into this category? Males, diabetic patients, pregnant patients, pediatric patients, geriatric patients, or lupus patients. So, with that being said, which patients would have to be on antibiotics for at least 7 days? So they can't be on antibiotics for 3 days or 5 days. At the minimum, if they get an infection, they have to be on antibiotics for at least 7 days. Who falls into that category? Pam Pam said male. Very good. Everyone on the live is saying male. Very good. Who else? Everyone on this list. Everyone on this list, if they have a UTI, that UTI is considered complicated and they have to be on antibiotics for at least 7 days. If it's a male patient, if it's a diabetic, listen, if we know anything about diabetics, we know they're full of what? Sugar. Guess what loves sugar? Bacteria. They love sugary, moist, dark environments, right? So any patient that's diabetic, if they get a UTI, it's considered complicated. Any patient that is pregnant. Now, here's the thing. let me be more specific because the boards expects you to know this. If the patient is pregnant, she's going to go in for a regular checkup. Every time she goes in, we take urine. If we find bacteria, we find nitrites, we find WCs, find RBCs, we find protein in urine. We see those symptoms of UTI. Even if she's asymptomatic, she still has to be on antibiotics. Boards expects you to know this, okay? So when it comes to the pregnant patient, even if she's asymptomatic, because she's pregnant, she has to be on antibiotics, and it's going to be for more than 7 days. Pediatric patients. I already told you, if it's a pediatric patient, they're going to be on antibiotics for how many days, guys? 10 days. Don't forget it. Don't say I didn't warn you. Geriatric patients. Why? Remember, the older you get, it's wear and tear on the body, okay? They're going to be on antibiotics for 7 days or more, and the lupus patient. Let me be more specific about lupus because this is something else that boards expects you to know. Let me fix the camera for you guys. Why lupus? Well, really, anyone that has an autoimmune disorder or is immunocompromised. And guess what? If you have an autoimmune disorder, you are immunocompromised. So anyone, HIV, AIDS, cancer patients that's getting chemo or getting radiation, any patient who just got an organ transplant and they're on what? High dose steroids, a lupus patient, any patient with, myasthenia gravis, the list goes on, right? If they have an autoimmune disorder or they're immunocompromised and they have an infection, they're going to have to be on antibiotics for at least 7 days. One more question. How are you guys doing on the live? Okay, let's go. Type in your answer. Okay, so you have a patient that comes in with severe one-sided flank pain that comes in waves. It may cause nausea, vomiting, usually has hematuria and urine, and may be pink tinged. What do you suspect that diagnosis to be? Again, severe one-sided flank pain. That pain comes in waves. The pain may cause nausea and vomiting. Usually in the urine, we'll see hematuria, and sometimes that urine may be pink tinged. I'm going to give you another hint because on boards, they like to give, I don't remember the word they use, but I'm just going to explain it because I can't remember the word that they use. But this patient can't sit still. They're all over the place because the pain is so severe. They're trying to find a position to get comfortable. So they're doing this. They're doing this all over the place. They're oh, here's a word they like to use. And they also like to do prostration. Postration or prostration. I'm not pronouncing that correctly. But anyway, that's like when they get down like this. It's very painful and they're trying to find position that makes them feel better. Oh, I'm so proud of you guys. Kidney stones, nephrolithiasis, stones. Very good. This is what we would suspect. Kidney stones. Okay. So here's some hints. One-sided flank pain. When you see one-sided flank pain, you should suspect that the kidney's involved. Maybe it's kidney stones. Maybe it's pyelonephritis. It could be something else, but you should be thinking kidneys, right? Comes in waves. Why comes in waves? Because that stone can move, right? So you have the pain, then it kind of goes away a little bit, then it comes back, then kind of goes a little bit. Nausea and vomiting, hematuria. That urine may be pink tinge from the blood. Something very important that you're going to teach this type of patient is what? Stay hydrated, because the number one risk factor for reoccurrence is dehydration. So you're going to teach them to always drink fluids, to always walk around with a water bottle. And if it's hot outside or they're exercising or they're sweating, to make sure they're drinking extra fluids so they do not get dehydrated. I spelled it incorrect. Sorry, guys. My spelling isn't the best. So, and guys, this was just a short series. Listen, I want to say this to you. I've been getting all the shade, all the shade. I don't get the emails directly. It goes to my assistant, but anything my assistant feels important, it comes to me. And he's been sending me all of the emails from the NP students throwing shade. I've got it. I get the picture, and I give my word that I'm going to try my best and just be more consistent in producing content for you as well. because you guys matter. You guys absolutely matter. And no, you're not the chopped liver. So I'm going to try my best to start making and be more consistent in producing content for you guys. Okay. So anyway, this video, I hope you guys found it to be helpful. Listen, guys, I may tell you a joke, but I'll never tell you a lie. If I talked about this, that means it's important for you to know for your boards. Before you go take your boards to be an NP, make sure that you cover this information in depth and you know it so that you can recognize those little red flags when they give it to you. Thank you so much for watching. Let's see how you guys did.